This is a neuro case presentation by Group N entitled Idiopathic Stabbing Headache. This case presentation is based on a case report entitled Idiopathic Stabbing Headache Associated with Monocular Visual Loss by the following authors, published on May 2000. The patient is a 27-year-old man. He presented with stabbing, sharp pain in the right temporal area. This was associated with nausea and complete loss of vision in his right eye, which he described as a black disc with sparkles of light around the edge. He noted multiple episodes, each lasting a few seconds, that occurred during a 3-hour period. And between episodes, the patient was free of headache. The visual loss and headache were precipitated by bright light. The patient had taken oral acetaminophen and diphenhydramine hydrochloride at home. However, this offered no improvement. The patient has a history of migraine with aura since 1995. He revealed that his father also had a history of migraine. The patient's vital signs were as follows: blood pressure of 143/70 millimeter mercury, heart rate of 90 beats per minute. On urologic examination, his visual fields were full, with normal fundi, and the cranial nerves were intact. No abnormalities were seen in the CT. To recap, these are the pertinent data of this case. The patient was a 27-year-old man who presented with stabbing associated with nausea and complete loss of vision in his right eye. He noted multiple episodes, each lasting a few seconds over a 3-hour period. The visual loss and headache were precipitated by bright light that lasts for several seconds. He took oral acetaminophen and diphenhydramine hydrochloride that offered no relief. He has a 5-year history of migraine with aura. His father also had a history of migraine. His blood pressure was recorded at 143/70 millimeter mercury. His cranial nerves were intact, and there were no abnormalities seen in the CT.
Idiopathic stabbing headache, or ISH, was first described by Lange in 1964 as ophthalmodynia periodica, and in the second edition of the International Classification of Headache Disorders, it was revised to primary stabbing headache. Primary stabbing headache is characterized by transient stabbing pain localized in the head and rarely in the face. It may be a single stab or a series of stabs lasting from 1 to many seconds. In studies, 80% of stabs may last for 3 seconds and rarely for 10 to 120 seconds. The pain have been described as ice pick-like pains or jobs and jolts, and the frequency of attack is low with 1 or few per day. Primary stabbing headache appears to be common in patients with other primary headaches such as migraine, TACs, and hemicranial continua.
Various studies by Rasmussen B.K. and Olesen J. in 1992, Pereira Monteiro J. Safalias in 1995, Strasdad et al. In 2001, Pareja G.A. et al. In 2010, have reported different numbers in terms of the prevalence of idiopathic stabbing headache. It ranges from 0.2 to 35%. The most notable of these studies is the one by Strasdad et al. In 2001, also known as the Vegas study, as it is the largest epidemiological study on idiopathic stabbing headache, and concluded that it has a prevalence of 35.2% out of their 1,838 individuals. The reason for these variations in terms of their prevalence is because PSH is more commonly associated with other headache disorders according to Dodik DPJ in 2006. He also concluded that 42% of the patients who have migraines also reports with PSH. There are limited studies that focuses on isolated cases of PSH. According to Liang et al. In 2014, 1.5% of their patients at a tertiary neurology clinic in China complained of PSH alone. Tugba et al. In 2008 also reported that 12.6% of their patients in a Turkish headache clinic reported isolated PSH. Unfortunately, there have been no epidemiological studies of ISH in the Philippines. In the adult population, PSH occurs more commonly in females with a female-to-male ratio of 1.49 to 6.6:1. The mean age of onset in the adult population has varied significantly in different studies and has ranged from age 28 in the largest epidemiological study of patients in Norway to age 47 in a smaller study of 38 patients in Spain and to age 53 in a veterans hospital of 80 patients in Taiwan. Pediatric cases of PSH have also been reported. However, it occurs less frequently in children in comparison with adults. In children, the mean age of onset is ages 4.5 to 9, and unlike the female predominance in adults, there appears to be no gender predominance in children. Pathophysiology for PSH is unknown, hence the other name idiopathic stabbing headache. But there are several proposed mechanisms. Irritation of trigeminal and extratrigeminal nerves and or intermittent impairment of central pain processing leading to hyperexcitability of neurons or spontaneous synchronous discharge of neurons. If haptic impulses are presumed to travel to the corresponding peripheral nerve distribution with the perception of the stabbing pain. In PSH with migraine, for a known reason, it triggers a wave of depolarization in a region of the cortex which also increases blood flow to that region in order to match metabolic demand. The depolarizing wave passes over trigeminal and extratrigeminal nerves will cause a release of neuropeptides antidromically. This is called the trigeminovascular theory. The neuropeptides like serotonin is released directly on dural blood vessels that leads to neurogenic inflammation. This results to a decreased response threshold of primary nociceptive neurons in the dural blood vessels. This is called the peripheral sensitization. Normal pulsations on intravascular pressure then inappropriately activates dural nociceptors, leading to paroxysms of stabbing headache. Other theories for its pathophysiology include dural sinus stenosis and brainstem inflammation or focal demyelination, although these theories would suggest a secondary etiology for the stabbing headache.
Clinical manifestation. It is manifested by a sudden stabbing pain located at the top, front, or sides of the head, or rarely the face. Pain is described as ice pick pains or jab and jolts pain that may occur as a single stab or a series of stabs. It may last in seconds and has an irregular intervals of its pattern of recurrence. According to Graber, Davis, and Matthew 2000, there are 3 reported triggers, and these are physical exertion, bright lights, and head motion. It may also be associated with other types of headaches such as migraine, trigeminal autonomic cephalalgias, hemicrania continua, tension-type headache, and cluster headache. Diagnosis of primary stabbing headache. Diagnosis is based on the clinical features and the distinction from other similar headaches. There are neither biological markers nor neuroimaging findings, so diagnosis is entirely based upon assessment of the clinical features. The International Classification of Headache Disorders 3rd edition or ICHD-3 diagnostic criteria for primary stabbing are the most sensitive to capture only primary headaches causes stabbing pain. It is also the latest criteria used for diagnosis and differentiating stabbing pain from other types of headaches. ICHD-3 defines stabbing headaches as transient and localized stabs of pain in the head that occur spontaneously in the absence of organic disease of underlying structures or the cranial nerves. In this criteria, it is required to have all the following statements from A to E. A. Head pain occurring spontaneously as a single stab or series of stabs and fulfilling criteria B and C. B. Each stab lasts for up to few seconds. C. Stabs recur with irregular frequency from 1 to many per day. D. No cranial autonomic symptoms. E. Not better accounted by another ICHD-3 diagnosis. And for the criteria of probable primary stabbing pain, A. Head pain occurring spontaneously as a single stab or series of stabs. B. 2 only of the following. 1. Each stab lasts for up to few seconds. 2. Stabs recur with irregular frequency from 1 to many per day. 3. No cranial autonomic symptoms. C. not fulfilling ICHD-3 criteria for any other headache disorder. D. Not better accounted for by another ICHD-3 diagnosis. Treatment. The main therapy for PSH is endomethacin. Endomethacin is an available brand in the Philippines. It is an indole derivative with analgesic, antipyretic, and anti-inflammatory effects. Its mechanism of action is a potent NSAIDs that reversibly inhibits COX-1 and 2. It inhibits polymorphonuclear leukocyte motility and decreases the mucopolysaccharide biosynthesis. It also has a vasoconstriction effect. Its dosage is 25 to 50 mg 2 to 3 times daily and is not an FDA approved for children less than 15 years old. Side effects is dyspepsia, GI bleeding, and also renal toxicity. Pharmacokinetics. Absorption. Readily and almost completely absorbed form in the GI tract. Food may decrease absorption. Bioavailability. 100% oral. Time to peak plasma concentration. 0.5 to 2 hours. Distribution. Distributed into the synovial fluid and also in CNS. It also crosses the placenta. Metabolism. Metabolized in the liver into glucuronide conjugate form and metabolites. It undergoes extensive enterohepatic circulation. Excretion via urine and feces. Terminal elimination half-life 2.6 to 11.2 hours. Alternative treatment options. Selective COX-2 inhibitors, etoricoxib, and celecoxib. Melatonin is a pineal hormone that is structurally similar to endomethacin but with fewer adverse effects. Most common side effects are dizziness, nausea, drowsiness, and headache. Onabotulinum toxin A. According to studies, no adverse effects were reported and may be logical treatment option for PSH. Others are gabapentin, topiramate, acetazolamide, and nifedipine.